I'll be starting the webinar, so folks will be able to come in, and we will be also starting recording in English.
Welcome, everyone. Good evening. Thank you for being here today. Today's event will be in English, but live interpretation will be available in Hindi. If you wish to switch to Hindi, the interpreter will explain how you may do so. फरीहा जी, प्लीज आप समझाइए कि भाषा को अंग्रेजी से हिंदी में कैसे बदल सकते हैं।
थैंक यू सबीना जी। आज का प्रोग्राम इंग्लिश में मुनक्किद होगा, जिसके साथ हिंदी में तर्जुमा मुहैया है। अगर आप हिंदी तर्जुमा सुनना चाहते हैं तो कंप्यूटर पर बने ग्लोब आइकॉन पर क्लिक करें। ये ग्लोब आइकॉन जूम स्क्रीन की निचली रो पर है और वहां पर अपनी जुबान फ्रेंच का इंतखाब करें। अगर आप अपने फोन पे जूम ऐप के जरिए हमें सुन रहे हैं तो वहां पर मोर का निशान देखें या 3 नुक्तों पर क्लिक करें और लैंग्वेज इंटरप्रिटेशन में जाकर फ्रेंच चूज करके डन को क्लिक करें। शुक्रिया सबीना जी, गो अहेड प्लीज।
Great. Thank you again, everyone, for being here today. Welcome. My name is Sabina Vorha-Miller, and I'm the co-founder of the South Asian Health Network. I want to start by acknowledging the land that I am on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat people, and is now home to many diverse First Nations, Inuit, and Métis peoples. The South Asian Health Network is very honored to partner with these 13 incredible community organizations, including Belfort, Punjabi Community Health Services, Black Creek Community Health Center, Indus Community Services, Black Health Alliance, MCIS Language Advocacy, Rexdale Community Health Center, Unambiguous Science, Black Health Task Force of Peel, Latin American COVID Task Force, Chayabad COVID, and Korea Community Health Center. Special thanks to MCIs and Language Advocacy for providing us with the technical, logistical, and language support for today. If you have any additional questions or would like resources, please visit our website at https://southasianhealthnetwork.ca. And with that, it is my utmost pleasure to introduce you to our moderator and speaker for this evening, both of whom have been exceptional physician advocates during this entire pandemic and beyond, and simply people that I truly respect and admire so very deeply. We have our moderator for tonight, who is Dr. Naheed Dosani. Dr. Dosani is a palliative care physician who cares for homeless and vulnerably housed individuals with dignity and compassion, whether in a shelter or on the street. He's the founder of the world's first mobile palliative care program for people experiencing homelessness, the PEACH program at the Inner City Health Associates in Toronto, Ontario. During COVID-19, Dr. Dosani has also served as the medical director for the region of Peel's COVID-19 isolation housing program. The Canadian Society of Palliative Care Physicians recognized Dr. Dosani with a humanitarian award in May of 2019, and the Canadian Medical Association celebrated his work with the award for Young Leaders in 2020. Welcome, Dr. Dosani.
Thank you very much.
And our speaker tonight is none other than Dr. Abdu Sharkawy. Dr. Sharkawy is an infectious diseases specialist with the University Health Network and an assistant professor of medicine at the University of Toronto. He has a keen interest in communicable diseases and providing public education across multiple platforms to raise awareness and offer guidance for best practices. He has been a leading voice in Canada's medical community while fulfilling his role, particularly via a prominent media presence as CTV's lead infectious diseases analyst and medical correspondent since the onset of the pandemic. Welcome, Dr. Sharkawy. We are so incredibly grateful to have you both here this evening.
Thank you so much.
And with that, Dr. Dosani, the floor is all yours.
Thank you so much for that kind introduction, Sabina. And I'm really excited to be here with you all, and so excited to join Dr. Sharkawy for a conversation tonight about vaccines, about COVID, answering key questions that are often asked in our discourse. I think in any forum like this, it's important to set some context. It's no coincidence that we are holding a series of these town halls and forums. And thank you to the organizers and to my colleague Sabina, who's done an excellent job of really providing access to information through her various initiatives, including this one. One of the reasons we're here today is to really recognize that COVID-19 has not been an equal opportunity virus. It's been a virus that has disproportionately affected people in certain communities. We've all really heard about the tragedy in long-term care, and that's important to talk about. But another hard hit, and arguably the other hardest hit community, has been racialized people, and particularly low-income racialized people. And I think it's important to start with context to say that, you know, there was a time in this pandemic where even accessing race-based data was difficult. You may remember the first wave, and it's easy to forget these narratives because so much happens. But there was a time when our policymakers and some of our elected leaders said we don't need race-based data because this virus affects us all equally. And that could be anything further from the truth. There, you know, you can take any city across Canada, and the hardest hit have been racialized people. In a city like Toronto, 83% of cases in the first wave affected racialized communities. That has not fallen that much. In fact, 70% of cases of people who are hospitalized of COVID are among racialized people as well. And so the race-based data just opened the door to a series of questions, but it also led to further conversations, including conversations that have to do with the narrative. There was a time, and we still see this now in public discourse and conversations and in the media, where sometimes people who are racialized are blamed for the high COVID rates in their communities. There, for example, was the festival of Diwali, when many, Hindus and South Asians celebrate, and there are pictures that would show up on social media platforms of people at parties, and a lot of the media headlines blamed South Asians for the high rates of COVID in places like the region of Peel, when in actuality, when you look at the evidence, it was a precarious employment and a lack of healthcare resources that were actually driving these findings. We didn't see the same narrative in our media when it came to Christmas time, for example. And so, this really does make a difference. The other thing to really consider are what are the actual drivers of higher COVID rates in racialized communities if it isn't the color of a person's skin, because that's my argument, that it's not race, it's racism. And when we talk about racism, we talk about structures of racism, and we talk about systemic racism. Well, lo and behold, many of the communities that have been hard hit by COVID-19, these racialized communities are often dealing with other problems, other social inequities that lead to higher rates of COVID-19. In these communities, you'll typically see that people live in more dense accommodations, high-rise buildings, multi-generational households. You'll also see that poverty is a common denominator, or lower income status. Also, many people who are racialized are essential workers. And it's not that they're getting or have been getting COVID where they live in their home. They've actually been contracting COVID at work, in their workplaces. So when you dig a little deeper, it's really the structural factors. The silver lining, more than ever, we're talking about racism, and we're talking about how social inequities are driving COVID-19, because if we don't talk about it, we're ignoring a big part of the picture. And it's more relevant than ever because of the conversation around vaccination. There is a deep mistrust of healthcare, of government, of institutions in traumatized communities, in communities who have been let down. This pandemic is no different. And that has been labeled as vaccine hesitancy. And what we're trying to do in conversations like this is acknowledge the hurt, and acknowledge the pain, acknowledge the trauma, and convert the feelings of mistrust into trustworthiness that we hope we can derive and connect with for people in our communities, for racialized people, for people who've experienced trauma, so that they recognize the importance of the COVID-19 vaccine, and so that we begin a discussion that is one of many that need to be had. But amidst the pandemic, this public health emergency, addressing vaccine hesitancy and addressing the racial background and differences and inequities is more important than ever. And I hope that kind of frames the conversation for how we're here, why we're here. And it's a real honor to join Dr. Sharkawy. Not only do I get to watch you on TV in my living room, but now you're on my computer as well. This is really cool. So I'm really excited about this. And the thing about Dr. Sharkawy is he's got a great sense of humor too. So I hope you guys get to see that as well. He's making me laugh in the private messages before the session started. Listen, I think we got to start somewhere, right, Dr. Sharkawy? So I think a reasonable place to start is, what are the different types of COVID-19 vaccines that are available to Canadians now, and how do they differ?
Excellent question. And just before we start, I want to acknowledge the same acknowledgement that Sabina started with. Unfortunately, I can't do justice to all the names of our Indigenous ancestors who helped to pave this land for us and give us the privilege of being on it. So I will do that. And I want to thank Sabina in particular for this tremendous initiative, and yourself, Dr. Dosani, for just being a wonderful advocate, an outstanding presence, and a champion of the people in a time when I think we need to really stand behind everyone who has been underserved, dismissed, disenfranchised, undervalued. And if there can be anything good that comes out of this pandemic with all its loss and all its suffering, is taking a moment of pause and determining that we need to change. We need to not accept the status quo, the same structural inequities that have caused too many people to die, too many people to suffer too long, especially within the very communities that we're trying to reach. So thank you so much for that. I'm privileged and proud to be a part of any initiative that can help in that regard. I think it's very important to understand, even before we get into the different types of vaccines, to really help put people at ease, to understand that the vaccines are not unsafe because of how they were developed and how quickly they were developed. So if you'll just give me the liberty of just touching on that point first, I think I'm happy to explain the differences in the types of vaccines.
For sure,
A
go
great
ahead,
deal
please.
of mistrust, I think, has not surprisingly been raised because people will say, how is it possible that you've gone from a moment where we didn't even have a name for this virus to actually having multiple vaccines that you're trying to convince us not only work, but are safe and are not going to harm us in such a short period of time? And that's understandable. The history of vaccines is such that we go from identifying whatever organism it might be to trying to establish an experimental vaccine, using it in animals, and then using it in different patient populations and gaining enough people and watching their response to these vaccines over years. Sometimes it takes decades before you have the amount of confidence that you need to say, number one, this vaccine works. Number two, it's safe and it's not going to cause any harm. There are some really important differences which made us follow a different timetable for this vaccine. The first is we're seeing a virus and a disease that's spread so rapidly across the world in a way that we haven't seen in 100 years, frankly, since the flu epidemic of 1918. So we're dealing with an entirely different level of urgency, which means that we have to work a lot harder and we have to work a lot more quickly to make sure that we are using the science, we're using every resource that we have to create this vaccine. But while we're doing that, we didn't break any rules. Instead of taking 5 to 10 years to find 30, 40, 50,000 people who were ready to become the volunteers to do the vaccine trials, we were able to bring those people together in a few months. It's the same number of people. We just decided that it was important enough to get those people to be part of the trial in a few months. That's perfectly fine from a science standpoint. Similarly, when we looked at the safety results, because it often takes so long to just complete a trial, it obviously is going to take a proportionally similar amount of time to determine if the safety results are going to be ones that you can have confidence in. When we looked at all of the trials that were done, we looked at the safety results at least 60 days after half of the trial participants had completed getting their dose. So that is the time frame within which serious safety issues were being looked at and considered. If we go back in history and look at all vaccines, since the beginning of vaccines, the beginning of the advent of vaccines in preventing serious diseases, we know that 90% of serious side effects occur within 45 days. 45 days of receiving the vaccine, not 6 months later, not a year later, not 5 years later. So that's a pretty good level of confidence as to what kind of timetable we're looking at to look for a problem. These vaccines went beyond that 45-day window and went all the way to 60 days. And what sort of side effects did they find? They found, I think, what we would expect to get from a needle in your arm in something that's triggering your immune system. A sore arm, a little bit of a low-grade fever, for some aches and pains, maybe a little bit of nausea. The most serious side effects that were ever identified were anaphylaxis, which are potentially life-threatening. I think the last data shows that there were only about 65 cases of this, all of which occurred within 30 minutes of receiving the vaccine, and none of which were fatal. So everyone that got even the most serious, potentially life-threatening reaction from these vaccines not only had it pretty quickly, so it didn't come up as a big surprise, and most of them were probably being monitored, and this was being witnessed while they were in a doctor's office or a clinic somewhere, and everyone survived. So this tells you that the science and the process that was used to develop these vaccines was safe, there were no rules being broken, and that the evidence behind the reactions to these vaccines points to the fact that they are also very safe. Okay, now let's move into what the different types of vaccines are and what's available here in Canada. Right now, we really don't have that many platforms. The first vaccines that came about were the Pfizer and the Moderna vaccines in late December, early January. These vaccines are based on what's called mRNA technology, okay? That's a genetic technology that we've actually been using for decades. It's not something new and scary. It's something that has been used and studied for a long time. Hasn't been used for a pandemic, but the technology is not new, and we have a good understanding of its safety, not only in animals, but in humans for other studies. So that's the first thing. What does this mRNA mean? It's a code. It is a code. It is a type of genetic material that is made in a lab. So it involves no animal products whatsoever. And it is engineered in a way that it will have a code inside of it once it's injected into your arm to tell your body to make the spike protein, which is the major part of the COVID-19 virus. It's an instruction for your body to do this, and your body will react by making the antibodies, the proteins that will then defend you against COVID-19 if you happen to encounter it anywhere you go at some point in the future. It does not change your DNA in any way, shape, or form. Once it has triggered your immune system, it frankly dissolves. It disappears. And the fat particle that covers it and allows it to get into your cell breaks down. Everything else that's in it also breaks down. Sugar, salt, and little bits of things like that are not harmful for your body, and they don't cause any serious reaction. Okay, so that's how the mRNA vaccines work. They are very effective because they are made in the lab. It gives us the ability to make it in big quantities and allows us to deliver it to people perhaps more effectively than something that requires a more labored form of technology. Now, you will know that the storage requirements and the transport requirements are a little bit more difficult for these vaccines, they do need to be stored in ultra cold temperatures. So that creates some difficulty in being able to use it everywhere, for example, as flexibly as something else that you might be able to store at room temperature or just in the fridge. But these vaccines work very, very well. We have the earliest data for them that shows they are very, very safe. I will point one other thing out too. A lot of people are very fixated and say that these are the best vaccines and everything else is not good enough because we hear the numbers 92, 95. That's the best. That's the grade A vaccine and everything else is inferior. Be very careful not to convince yourself that the numbers tell you everything. The numbers don't tell you everything, in particular because these vaccines were developed and the data that came from them came at a time when we didn't see a lot of the more challenging mutations, what we call the variants of concern, that we now see are causing a problem in many parts of the world. So some of the other vaccines have had to contend with their trials being done while those variants were circulating more. So it's not a fair comparison to say that the 62, 70, 80% with other vaccines is much worse than the 92 or 95% that you see with these mRNA vaccines. Very, very important to know that they all prevent hospitalization, they all prevent serious disease, and they all prevent death. And we're seeing that even in elderly people. So you should be very confident and very reassured that at the end of the day, all of the vaccines do what they're supposed to do. Okay.
Really appreciate that. I just wanted to jump in, Dr. Sharkawy. So, I think you've done an excellent job of reviewing the differences in the vaccines and the effectiveness. I think you also answered a key question that I was going to ask anyway, around, is one vaccine better than another? And I think those are really key questions that the mainstream audience asks. Now, I really want to get into some of the questions that our current audience here on this session are really zoning in on. A lot of people are thinking about vaccine effectiveness for sure, but a lot of people are wondering, has this been studied in racialized people? My mom is Black and she has questions about how the studies really looked at Black people, or my uncle is South Asian, and did they study enough racialized people? And is the effectiveness different in racialized people versus, for example, white people? I think it's a fair question, right?
It's an excellent question. And one of the good things about what we've seen and the diversity of trials and the different platforms is we have a vast range of geography that's been covered. So the trials have occurred in places like the US, the United Kingdom, where we know that there's a big South Asian population, for example, in Brazil, in South Africa. But by engaging these trials in geographically diverse areas, I think we have a more representative understanding of whether we think the vaccines are actually working in different ethnic populations. If you break it down, I was just reviewing the Astrazeneca data just yesterday, frankly, and I looked at it, and it was actually a fairly decent breakdown in terms of Blacks and South Asian populations, et cetera. Obviously, it's not perfectly equitable, but I think as long as you have a reasonable minority that is included, you have an idea as to whether or not there's going to be a signal of concern. The other thing that we should always be mindful of is when we look at the history of most vaccines, if we're talking about the flu vaccine, the pneumonia vaccine, shingles vaccines, hepatitis A and B, there's never been any evidence to suggest that there is a lesser response in people of color, in people of any particular ethnic makeup. And that should give us some confidence that we're not dealing with something that's new enough to raise any level of concern that it shouldn't work any worse in any of these racialized communities.
This is huge, and I think the conversation about effectiveness and studies happens on a population level, and then for racialized people, there's this sub conversation happening. And I think we need to dispel any myths that exist, and you've done that really well. I wanna transition to side
Can I
effects.
just follow
Yeah,
up on that just for a sec, just to give
go for
people
it.
more confidence? People might look at the Astrazeneca trial, for example, and say, you know, there's only 11,000 people. So, you know, is that enough for me to feel confident about, even if there was a smattering of people from the Desi community and from other South Asian communities? Well, that's where it's really important to talk about what we call real world evidence. So by the time the trial works and then it gets rolled out, then you're looking at 17 million, you know, across the European Union. And by that point in time, it's very clear that you're going to be getting a much more representative sample into racialized communities. There still may be some inequities, don't get me wrong, but it's going to pale by comparison to the scale that you may be worried about when you look at the trial data alone.
There's the trial data, and then there's the real world experience that really hits home. You talked a lot about side effects, so thank you for your overview, because you kind of covered typical side effects from the vaccine. But there was this recent controversy around like blood clots, and I was all over Twitter, and I'm sure there's a lot of misinformation that came out of that, probably on WhatsApp and Instagram, and it's all out there. Can we just talk about blood clots as a side effect of the COVID vaccine? Is this something to worry about? What's the deal there?
So I'm really glad that you asked that. And I think that this issue is very, very reflective of a lot that we have seen throughout this pandemic. It's very easy to put two things together and create an association, whether it's between COVID or it's a vaccine or anything else, and draw a line between them, and unfortunately create a lot of fear, a lot of panic, and a lot of hesitation in terms of what you should believe. And it's perfectly understandable. The problem is that there are so many different sources of information. And unfortunately, much of the media allows, I won't say disinformation to happen, but it will really amplify stories that create fear, sometimes to the detriment of the truth. So let's be honest here. Yes, there were blood clots that happened in under 50 people. So certainly, this is not something we should completely dismiss. It is our responsibility to look at those people and question whether or not there could be any association between the AstraZeneca vaccine in particular, or any vaccine that's being given for COVID, or vaccines in general. Is there a reason to believe that if you give enough vaccines to enough people, that there's going to be a greater tendency to have blood clots? So let's take a step back and just think about the science first of all, and the history of vaccines, and then we'll look at the numbers and decide for ourselves if any of this makes sense. We have no history. We have no body of evidence anywhere over the last 150 years of any vaccine being associated with producing blood clots. Blood clots tend to form because someone has some sort of tendency within them, whether it is a genetic problem that they are born with, or whether it is something that is acquired through smoking, for example, a cancer that they may or may not know that they have, if they have been unable to move and are immobilized for some reason, have had a surgical procedure. These are well-known risk factors that will cause blood clots to form in our legs and potentially to move into our lungs. Those are irrespective. They have nothing to do with vaccines. So there has been no history of vaccines causing blood clots for any particularly good reason. Now, let's move a little bit more closely and zoom in on the AstraZeneca vaccine, since that's the one that apparently has caused all of the worry. What's in the AstraZeneca vaccine? Well, it's got this viral vector, okay, that is called adenovirus. And in the case of this vaccine, it's called the chimp adenovirus. So it's a monkey virus, and this adenovirus is something that Millions upon millions of people around the world will experience. It causes the common cold. It causes sore throats. It causes things that people get all the time. None of those are associated with clots. There's never been an association with the common cold and blood clots. Okay? Let's look at the rest of the ingredients in the AstraZeneca vaccine. They include a lot of the same things that you would see in the other COVID vaccines: salt, sugar, a little bit of protein. Okay. These are things that break down fairly quickly after the vector is delivered into the cell and triggers the immune system. No association whatsoever with clots. Okay, you don't believe me. Let's look at the numbers. Let's examine the numbers and ask ourselves if this signal is something that we need to become alarmed about. If we look at a random population in most parts of the world, the rate of getting these blood clots in your leg, in your lungs, anywhere else is 1 to 2 out of 1,000 people per year. Okay? It's a pretty small number, but again, across a population of millions of people, that will be a significant number. Let's look at the number of doses of this vaccine that have been administered just in the European Union. 17 million. And we have under 50 cases. In fact, I think at last count, it was somewhere around 37 cases. If you do the math, that is incredibly low and even lower than what you would find in a general population. So you're kind of trying to convince me that the odds of getting struck by lightning or winning the lottery are somehow worrisome enough and equivalent to the same level of concern we're dealing with blood clots. And I'm finding it very hard to believe that that's the case. So believe in the science, believe in the math, believe in the history of vaccines, and remind yourself that if you're avoiding this vaccine and you don't have an alternative that is readily available to you, you're putting yourself and your community at risk, because the risk of COVID is certainly a hell of a lot higher than 37 out of 17 million.
Yeah, and it just hits me that, in a lot of these conversations, they're very fair questions that get asked, but the likelihood of getting COVID is much higher than a lot of these, like, for example, blood clots and a lot of the other questions that have been asked around that. There was other controversy this week that came out, and it's an ongoing conversation. I'd love to get your thoughts on it. NACI, the national organization that supports us around immunization suggestions and recommendations, recently recommended a 4-month delay between the first and second dose. Now, this is a little bit rough for some people because some people have already had their first dose. So what are your thoughts on this? And, what implications does this have? And I think a lot of people are wondering, is this because they don't have enough supply? They're just like making up and engineering evidence now? I mean, I think it's a fair question. People are somewhat cynical at this stage.
It's a very fair question. And I think what's very important is to make sure that we are completely honest about what we know and what we don't know, but we have a pretty good sense of confidence about. And those are two very, very different things. And if we try and convince people that what we don't know is in fact what we do know, that's where you lose people and people start not trusting. Whether it's Health Canada or the National Advisory Council or anybody else who's trying to convince them about the vaccine and how you should take it. So let's break down what we actually know and then try and distinguish that from what we don't know and why we think it's still a reasonable idea to use this strategy. Okay, let's go to the first and earliest studies that were done for COVID vaccines, which were the Pfizer and the Moderna trials. And those were done with 3 weeks or 4 weeks between the first and second dose. And we know that they worked very, very well and got the effectiveness rates of about 95%, and everybody felt great about that. But then when we looked back and examined what happened, not just at 3 weeks and at 4 weeks, but we looked at people. Some people didn't get their doses, their second dose, at exactly a 3-week or a 4-week interval. There were actually a number of people, not a lot, but a number, who did receive their second dose as late as 42 days, and some as late as 48 or 49 days. And when we compared the people who received their vaccines at those periods of time and compared them to the same people who got the vaccines at exactly 3 weeks or 4 weeks, there was no difference at all in terms of the rate of COVID in those people. So even there was some degree of hope that suggested maybe we don't need to stick to exactly the same protocol that was in the trials. Okay. Now, what else can we do to look at to think about whether or not it needs to be dosed at exactly that time interval? So when you look at the graph, there's a great graph, and I wish I had it with me to show you, but there's 2 lines. Okay, and I'm just going to kind of draw it with my hand here, and I don't know if this is showing backwards for people or not, if I should do it like this. But the idea is the first line in the graph is the line of the rate of rise of COVID over time. And that line has the same contour, whether you're talking about the people who didn't get the vaccine, the placebo, and the people who did get the vaccine. Where that line starts to separate and open up like this is around 14 days. Okay. At 14 days, the people who have gotten the vaccine are now starting to develop some antibodies. So, of course, they're not going to see the rate of COVID at the same level that people who didn't get the vaccine. That line continues to be flat, and it stays flat, and it stays flat, and it stays flat. Where do we see that first little blip where it doesn't stay flat anymore? It starts to go up just a little bit so that it's closer to the placebo group. It's at around 90 days. That's an interesting thing. What that tells us from an immunology standpoint is it means that maybe the booster effect, maybe that extra second shot that you need doesn't necessarily need to be given until even as far out as 90 days. If you had to give it earlier, we might expect to see that rise of that line closer to the people who didn't get a vaccine well before, maybe at 42 days, maybe at 50 days, but we don't. So I think that that is worth something. Okay, you don't believe me. You don't believe me. That's okay. Let's look at the Astrazeneca trial, which did a nice job. And it actually did a different study that compared dosing intervals in people before 6 weeks, after 6 weeks. It went all the way to 90 days. And very interestingly enough, it found that the difference between the number of people getting COVID actually widened. The benefit was actually better if you waited to get the second dose at a later period of time. And you might think, that doesn't make sense. Shouldn't you have more of an immune system earlier on? And shouldn't that protect you even more? Not necessarily, because what happens is that it's a timing issue. And your body's immune system works in a way that requires a boost at a particular time where it doesn't interfere with what's already going on, with what's already being charged. To me, I like to think about it like, you know, in older cars, when you put the key in the ignition and you start it, and then sometimes you forget that the car is already on, you know, and you absentmindedly turn the ignition again, what happens? You hear that sound. I've done that enough times in my life. You've kind of disrupted the whole computer system in the car and have done something that you think is good, but it's not. And I think that can happen to your immune system potentially if you give that second dose earlier. You might still be able to start your car if you turn it on again, but you might have maybe not had a smoother delivery to your engine, and maybe you won't get out of your driveway just as smoothly as you did had you just recognized it. So we have real world evidence, ironically enough, from the AstraZeneca vaccine, the one that's getting a black eye undeservedly for exactly this. So 90 days good, I'm going to be honest. There's zero evidence to say that 120 days should work just as well as 90 days. I'm not going to stand in front of you here and lie because I would be. There is no evidence. If NACI has that evidence, I would urge them to step forward with that evidence. What I think they are saying is that it is perfectly conceivable that if 90 days is a good enough interval, that another 30 days should be just as fine. And what's really important here is we shouldn't say that we are going to say for sure everybody has to wait for 120 days. What we're going to try and do is aim to get everybody vaccinated sooner than that. But we don't want to reserve second doses so that we can prevent as many people from getting sick. We want as many people to get that first dose as possible. So that nice, smooth level of immunity we see from all of these studies is already established in as many people as possible. Young, old, racialized, non-racialized. Once we get people's immune system ready and going, the virus is going to run out of steam even before a second dose. And by that point in time, whether we're giving it at 6 weeks or at 90 days or at 120 days is going to mean a lot less.
And I think, you know, you've taken us on a journey there, and I love the analogies, lottery tickets and cars and ignition starts. This is perfect for me. It makes a lot of sense, but we will talk about rollouts. We're going to get to rollout questions in a second, because I think that's an interplay there that needs to be discussed. I have many people I care for who've gotten COVID, unfortunately, both in hospital that I care for and also in home care. And they're asking me a really important question. Can people still get COVID after they get the vaccine, right? So there's people who are saying, like, I already got COVID, like I don't need the vaccine, you know, like, and there's all permutations of that. So can you talk a little bit about that?
Absolutely. Excellent question. And there are so many different possibilities here that need to not be ignored. The first thing is, let's look at the math, okay? These trials, even the best of the best, 95% effective. That means 5% of the time, even in the best of circumstances, you're going to get COVID, even if you got the vaccine. So you don't know if that's going to be you or not. So getting the vaccine is not 100% guarantee that you're going to be protected. Maybe you're only going to be protected after that second dose. I don't know. What if you've already had COVID? Well, having COVID doesn't necessarily mean, number one, that your immunity is good enough to prevent reinfection. And number two, that it is durable enough, that it's going to last long enough without some help. The older you are, the more health conditions you have, the harder it's going to be for your natural immune system to do that work by itself. Even more worrisome, now, luckily, this isn't our problem as much right now, but in Brazil, where they have the mutation that's quite deadly and spreads a lot, there are a lot of cases of people who have had COVID who are getting reinfected. And that's a problem. They're getting reinfected with the Brazilian variant when they had a different one before. So the simple answer is, even if you've had COVID, you should seek the vaccine. It is still safe for you. It will not harm you. The real question is the timing and how easily you can access it. But the principle should be get it, get it, get it. It will almost always be of more benefit to you than it will be of any risk.
Super clear. Thank you, Dr. Sharkawy. We're going to just transition into discussion about the rollout, and then we're going to move into some audience questions, and I keep them coming in the chat. We have some really good questions, and we'll ask Sabina to come back so we can do a little bit of a Q&A. But a lot of people are thinking about rollout, because it's one thing to talk about the effectiveness of the vaccine, but what's the point if, like, I'm not going to get it and I don't know when I'm going to get it? And there's an art to the rollout. There's a science to it too. So when you think about elderly seniors in our communities, when can they expect to receive the vaccination? I understand this breaks down differently by age group. How will they be informed? What's the process? Can you break it down for us?
Yeah, it's an excellent question. And part of the problem is that there's been so many different moving parts. There are so many different people that we need to become involved to make sure that all of our members within the community, especially vulnerable seniors, those with high-risk medical conditions, essential workers, etc., get the vaccines and are able to access it and understand it. There are some logistical problems that I think are going to challenge things. Everybody knows that the portal that opened up a few days ago was a bit of a disaster. It took a very long time for a lot of people to navigate it. Not everybody has a computer. Not everybody is computer savvy. Not everybody has the vision, the actual visual ability to use a computer. So we're going to have to rely on a lot of different parts of our healthcare system to help support people. I think a big part of that is going to be family physicians, primary care networks. We're starting to gain a little bit of traction in terms of helping to get our family physicians more connected with the public health units so that they can identify their own patients more quickly and give them the information that they need to say, you're up, Mr. Singh or Mr. Khan or Mr. Chow or Mrs. Lee, and this is when you should come in. We don't have that really put together very well, but I'm confident that that will happen at some point. The other thing we're going to have to roll out a little bit better is getting the vaccines to the people, because there's a lot of people who, because of their physical limitations, etc., they can't come to a vaccine clinic or to a family doctor's office, and we're going to need to use resources to get those vaccines to people who can't leave their homes or their institutions. There's a lot of retirement homes that are not deemed high risk, and we still have to get vaccines to them. The reasonable time frame, if you want me to give you, I think, an educated guess, is going to be between now and hopefully the end of April, within which we can see a lot of people who are at least between the ages of 65 and 80 getting their vaccines. And a lot of it will also be a product of how quickly the vaccines are coming. So we're actually running out of vaccines, which is a good thing to a certain extent, but it's not a good thing because we need more to replace the ones we're running out of. We've been told we're getting 1 million doses of the Pfizer vaccine on a weekly basis, starting next week. That's great news. The Astrazeneca vaccine is already available. And enough people, unfortunately, have turned away that it now will be available to more. And now we have said unequivocally, it is safe and should be given to people even over the age of 65. So I think breaking down those barriers is going to help a lot. I hope I'm wrong in terms of things happening even sooner, but I think it's going to take at least the next couple of weeks to work out some of the wrinkles of who we're going to get involved to really drive this. And if we're going to get 24/7 clinics going, 24-hour clinics going, because I think we really need that to get the people in need to get their vaccines more quickly. We can't rely on an 8 o'clock to 5 o'clock, by difficult appointment only schedule. If we're going to make this work, we're going to have to be more flexible. And I think we will be over time.
Absolutely. Dr. Sharkawy, I have learned a lot in this session with you. You are a wealth of knowledge, and I really appreciate the ways that you break down information and make it accessible to people, and particularly communities that are accessing the session today. I really appreciate this discussion. I'd like now to invite Sabina to come back to the virtual stage. Dr. Sharkawy, I'm going to leave you in the capable hands of Sabina for a neat Q&A. There's a ton of questions that are happening. I'm going to hand it over to you now, Sabina. Thank you, Dr. Sharkawy. Thank you, Sabina.
Pleasure. Thank you.
Thank you,
so much.
Naheed. That was excellent. What a great Q&A. Actually, I learned a whole lot today as well. So thank you, Dr. Sharkawy, and thank you, Dr. Dosani, for your incredible question and answer today. I think that you covered a really large ground, especially since we were getting so many questions through email, through Twitter, DMs as well. And it's just been fantastic in terms of the number of questions we received. So a couple of things that have come through. Dr. Sharkawy, you mentioned, we briefly talked about, whether someone has already had COVID, whether they should get the vaccine or not. And of course, you said unequivocally they should be. The question that came up was to clarify, because some people have been told they need to wait 3 to 6 months after they've had COVID to get the vaccine. And could you clarify on this?
So that is unfortunately, I think, a product of our earlier level of understanding of how quickly we thought antibodies would be mounted, and how well we understood whether COVID could lead to more complications, without further protection. I think that what led to the 3-month window in particular was we know that in general, even people with weakened immune systems will by that point in time mount an antibody response. So it stands to reason to say, give it 3 months and, by that point, you're probably okay. The problem with that recommendation is a lot can happen in 3 months. And you may be exposed again. And if you're elderly, for example, or you've got diabetes, or you have any other risk factor, you're putting yourself in undue risk category. And why would you do that? It doesn't make any sense. The only caveat that I think is important is you do need to go through that period where the acute phase of COVID has resolved. So you need to complete the fever and the awful hacking cough and the feeling fluish and all of that, which in general resolves within most cases a week, 10 days, maybe 14 days at the most. Okay, you don't want to get the vaccine at that time because the likelihood of your body being able to accept the vaccine and to actually make the immune system work is much, much lower. And that's just something that is universally accepted for any vaccine. You shouldn't get any vaccine while you're sick with a bad cold, a bad flu, not because the vaccine is going to harm you, but because your immune system's already a bit weakened. It's already fighting something else off. It needs a little bit of time to recover so that it can use the vaccine the right way and build up its immunity again and have it work for you. So get the vaccine for sure. Make sure you're just out of that early symptomatic phase.
Great. That's such a great clarification to that question. I know it comes up very often, especially because I think there's a lot of different numbers that people are given. Like you wait 10 days, you wait 3 months, you wait 6 months. So it's really good to have that clarity. Thank you. Another question that has come up very often is that what about getting other vaccinations? Is it a contraindication? Or and if it's not, then how long? How much time do you need to space between any other vaccination, whether it be something like HPV, whether it be a flu shot? Is there any guidance to that?
Yeah, very good question. Important question, especially, people were getting flu vaccines. Luckily, nobody really needs the flu vaccine anymore, which is amazing. But some people might be looking at getting an HPV vaccine, a shingles vaccine, a pneumonia vaccine for whatever reason. So what we are recommending is to separate any other vaccine before and after the COVID vaccine by 14 days. So there should be a month basically between any vaccine. So 2 weeks before or 2 weeks after. Ideally, you shouldn't have any other vaccines. And the simple reason for that is to reduce the risk of what we call interference. We want your immune system to be firmly focused on responding with COVID-specific responses, to make all the antibodies directed specifically against COVID. We don't want it distracted for HPV or for hepatitis B or A or anything else. The good news is nobody should be traveling anywhere right now, so you shouldn't be getting a lot of those travel vaccines anyhow, so it should be fairly easy.
Excellent. That's fantastic. Another question that comes up very often, and in fact, is definitely near and dear to our hearts as well, given that we both have young mini humans at home, is what about the vaccine for children? When can we expect this, and what does the data look like so far?
Yeah, good question. And, I've got 3 kids of my own, and I worry about them. Right now, I'm just worried that they won't tear each other's hair out more than anything else, staying at home. But yeah, eventually we all want our kids vaccinated. We want them to go to school knowing that they're safe. And ultimately, we want them to be able to interact with other generations in our family, with their, daddies and their nani johns and the rest of that. The good news is the trials are underway. And the initial trials, which started back in January and February, were from age 12 up with both Pfizer and Moderna. Unfortunately, it took a little longer than we had hoped for them to recruit enough people. But now there's even better news that there are trials starting for kids that are as young as 6 months of age, which is amazing. You might say, okay, but it took so many months for the adult trials to get done. Are we going to have to wait 9 months between getting all of the kids enrolled and then looking at the results? No. And the simple reason for that is we don't need as many people here. We know that fundamentally the vaccines are safe and effective. So really what we're testing at this point in time is dosing. We're looking at the perfect formula that's going to work. So instead of 50,000, 40,000 people that we looked at in the Moderna and Pfizer studies, we can get a very good idea from looking at 7,000 kids. And I think that that's what's being aimed at with the Moderna trial that's going to be launched very soon. That means we should be able to complete the trial, hopefully in the next few months. It means that if all goes well, we might have data by late summer. We might be then in a position where we get approval and we can actually start vaccinating kids sometime in the fall, which is incredible. It may not be before they start their next round of school, but if we can get it into them before Thanksgiving or even Christmas, that's amazing. That means that we have a really good sense of confidence that pretty much every age group in our population is getting some solid protection from this virus and is going to really make it more realistic that we can have that real bonding and that sense of community and family that we've been missing so badly, especially in many of our racialized communities where we know, that cultural customs and other, festivities and just part of the fabric of our community is so much a part of intergenerational, meeting and being together.
That is such an important question because I think it really is on everyone's mind. And I've said that in our last town hall as well. It's the same situation here. I have a toddler at home who's 4 years old. Cannot wait to see, grandparents as well once the grandparents are vaccinated. So it brings me to the question that we've gotten from a few actually members today is when can we, after we get our vaccination, when can we see our grandchildren? When can we see our family members? What's your answer to that?
Yeah, that might be the toughest question of all to answer. And the simple reason behind that is there are a lot of elements at play when you try and determine when you are safe and how safe is safe enough. So, excuse me, the first point really is how immune enough is being immune. Is it after the first dose? And at what point after? Is it after the second dose? And at what point after? We don't have a clear answer to that. Now, the CDC has come out with guidance that says that 2 weeks after the second dose might be a reasonable point in time, not an unreasonable consideration. But the question then becomes, what are you doing and with whom? Okay, and that's where things I think can become a bit tricky. At that point in time, I think you also have to be aware of the fact that whoever you're interacting with may not be immune. So your grandchild may not be immune. maybe they've had COVID and they're immune and they haven't been tested for it, or maybe they haven't. You don't know that. And until they've been vaccinated, there's still that theoretical risk that close contact with them, especially over an extended period of time, especially if it's indoors, might mean that you are still at some level of risk. Now, that being said, I don't think we're going to be very, very rigid, and we're going to be very harsh in terms of what recommendations we give for people to gather and get together, even between different generations. I think a lot of it is going to depend on what we're seeing in actual community rates. So we're going to have to see the numbers come down, and we're going to have to see those numbers come down consistently. And no more of this nonsense where we're seeing variants continue to spike despite not enough people vaccinated. We're going to have to see the variants go like this. We're going to have to see the vaccines go like that. And at a point where we feel that enough people in the community are vaccinated to feel that there's probably not enough virus out there to say that, okay, let's say we can say that you safely meet outdoors, with a certain number of people, or potentially even indoors, but with certain distance parameters, etc., that it makes sense. How that gets nuanced, I think, is going to really play out depending on what the actual numbers are in our community and how well they stay there, along with how many people are vaccinated. If they all work together really well, very conceivable that we can see small gatherings of grandkids with grandparents and multiple members of a household, indoors for something like Thanksgiving. Restricted numbers, that's a possibility, but I can't tell you exactly how many or if that's going to really work until we see how things play out over the next few months.
Yeah, so important. And I can't wait till we have some of that information as well. And so I think another question that, sort of ties into this has to do with certain populations that we still don't know, and we still are getting guidance that can sort of flip-flop. But what are your thoughts with respect to pregnant and breastfeeding people? It's one of the questions that came up in the chat. I know we talked about children, and so is there any data with respect to them?
Great question. Such an important question. And this is, again, coming back to the concept of, real world data versus theoretical fear or concern. So obviously, by design, vaccine trials don't include pregnant women. And the reason for that is pregnant women are deemed high risk. And you're concerned not only about the woman, but you're worried about that fetus inside of them. So we try not to put them at undue risk until we have more information from other populations. But sometimes people are human and they break the rules. And so in both the Pfizer and Moderna trials, people ended up getting pregnant. Not a lot, but somewhere in the neighborhood of, I think, 37, something like that. Of all the people who were vaccinated, who were pregnant, not a single one of them had a problem. They were all healthy. They all delivered their babies to term. All of the events that occurred, which were spontaneous abortions, miscarriages, or planned abortions, and there were a handful of them, occurred in the placebo group. So again, small numbers, but I think worth considering in terms of what happened here. And if we then just compare that to the theoretical risk of COVID compared to the risk of a vaccine, okay? This is a killed vaccine. There's no live virus in it. And we know that killed vaccines, which we use all the time for pregnant women, like the flu vaccine, pneumonia vaccines, etc., they're all very safe. They're very effective in pregnant women. We've been using them for years and years and years. These are all killed vaccines. We do know that women who are pregnant who get COVID have a significantly higher risk of bad outcomes during pregnancy, especially premature labor and miscarriages, blood clots, etc. So the risk of getting COVID is not minor, it's significant and much, much higher than the risk of any adverse event from the vaccine. And I just told you, some people broke the rules and they got into the trial and they did fine. And I also told you that the platform and the type of vaccine, same type of vaccine in terms of how it affects the immune system that we've used in many other vaccines, very safe. Breastfeeding, same idea. It doesn't reach the bloodstream in sufficient quantities to actually get into breast milk to do anything harmful, even if it was going to be harmful. Don't believe that. The stomach acid of even a small nursing infant is enough to destroy anything that's still alive in the vaccine ingredients. So no harm at all in giving it if you are breastfeeding.
Amazing. That's excellent. Thank you so much for that information. I think my last question actually is going to be very quickly, if we could talk about Johnson & Johnson, the J&J Janssen vaccine. We know that it is approved here in Canada, but we don't hear about it very much. And so could you tell us a little more about it?
Yeah, the Johnson & Johnson vaccine, to be honest, is probably the one vaccine I've probably been more excited about, believe it or not, than any of the others. And you might be scratching your head saying, really? Is it better than Pfizer and Moderna that had 95%? You know, that great math test that you come home to your parents with in grade 7, and then you're upset because they say, beta, what happened to the other 5%, right? It's still an amazing thing. And the reason for it is that even though the overall efficacy, if you call it the effectiveness, was somewhere in the range of between 60 to 70%, that's overall, the ability to prevent serious disease was excellent and still 100% effective against preventing deaths and hospitalization. So why am I so excited? I'm very excited because number one, it's one dose. You're done. You get it and you're done. You don't have to worry about whether you're going to get that second dose at 3 weeks, at 6 weeks. Do I trust the National Advisory Council? Do I trust Dr. Sharkawy? Who do I trust? You trust in science because the science in the trial showed that one dose was good enough and it did the trick by itself. So that's an enormous sense of relief just there, that there's no argument about what you need and how many doses. The other thing that's great about it, those ultra cold storage requirements that we talk about that make it difficult for the Pfizer and Moderna vaccine, to be stored at a particular temperature and to be, put together properly so that it doesn't fall apart before it's injected. None of that with the Johnson & Johnson vaccine. Very, very similar to a lot of the vaccines that we give for all kinds of other conditions. Can be stored in the fridge, can even last at room temperature for a long time. That means if we have to get to difficult to access populations anywhere, no problem. I don't need a special truck or a van with a freezer in it. I don't need somebody who has special skills that knows specifically how to manage this very fussy, mRNA vaccine. Nope. Anyone who's used to giving vaccines at all can give it. That might be a pharmacist, it might be a physician assistant, a public health nurse, a family physician. Pretty much anybody who's comfortable giving needles can give this vaccine. And what an enormous benefit that is for people who can't get around, who are more difficult to reach. That's just huge. And that's why I think this is the first vaccine that I use the term game changer, because it strikes all the right marks in terms of what it does to prevent serious disease and death and hospitalization. And it's more practical. What a great combination.
Oh my gosh, what a great way also to end our webinar today, because on that positive note that we need is just incredible. I think we do need good news right now, and vaccinations are really, the good news that we're all waiting for and hoping for. So this has been incredible. We've actually received over 50 questions through all of our different channels, and so apologies that we were not able to get through all of the questions today. We tried our best, but if there are any further questions, please reach out to us, email us. We can try and get you the answers. And we also have a lot of resources on our website, so please take a look at that. They may actually also address some of the questions that you have. And Dr. Sharkawy, thank you so much for today. It has been absolutely amazing, getting an insight, getting a part of your brain that you can share with all of us today. It's just been fantastic. And also, the analogies you use makes it really, really helpful and really easy for everyone to understand. So really thankful and really grateful to have you here with us today. So thank you for that.
Can I just have one parting thought that I think is important? You talked about analogies, and I think analogies are important for people to hang on to and help them make sense of what's going on. I think a lot of people are very, very stuck on numbers, and a lot of people are afraid, and they say, well, if it's not 90%, it's not good enough, I don't trust it. And I think that this is particularly the case with people who may not have perfect immune systems, or who may be elderly, or who may be on treatment that is suppressing their immune system, whether they have arthritis or they've got inflammatory bowel disease or any number of different conditions. I want you to remember that some protection, any protection, is better than zero protection. If you're avoiding the vaccine, you have zero protection. And I love the analogy that somebody shared with me the other day. If you're out in the cold and the cold weather is getting worse and the snow is hitting you, would you rather not have any clothes at all? Would you hold out and say, I only want a full parka, full mitts, full face mask, full winter boots, and I'm accepting nothing else? Or would you take a heavy sweater, a good set of mittens, a good set of boots, and know that that's going to keep you safe from frostbite and keep you safe just as well as if you had something that was heavier? I think the answer is pretty clear. Put on a coat, put something on. Don't leave yourself completely vulnerable and the people around you vulnerable. I promise you, something is much better than nothing, and something is probably a lot better than you think, especially when more people believe it.
Oh, absolutely. What a great way to end that. For me, I know for sure I would much prefer to have that thick sweater, the thick pants, and the thick mittens to keep us all protected. And I think what a great way to end this webinar today. So thank you, Dr. Sharkawy, for your incredible thoughts and for all of the education today. We're extremely grateful to have you here today. And I can say that for all of our audience as well. So thank you. I quickly want to tell everyone about our next town halls. We have one on March 22nd. This is going to be only in Spanish. It's going to be with 3 Spanish physicians from the GTA. And on March 25th, we're going to have one that is only in South Asian languages. So this would be Hindi, Punjabi, and Tamil, and there will be 3 physicians from within the South Asian Health Network. And this is going to be basically a Q&A style only. You come with your questions. We'll try and address as many questions as we can in these time buckets that we have. But as a reminder, the following 2 town halls will only be in either Spanish or Hindi, Punjabi, Tamil. There will not be any English in either of those 2. And with that, I just want to quickly leave you with our last slide, which is, I think my computer is saying goodbye as well. And it's just, that's our website. If you have further questions, if you need more resources, materials, please feel free to reach out to us. We're so grateful to have everyone here today. So thank you for joining us and have a good evening.